Hello and welcome to this VetLit podcast. VetLit Minis are journal club podcasts on a range of topics, small animal focused, so you can keep up to date even if you just have a few minutes spare. Today we're going to be learning about surgical mitral valve repair. Now, I remember when I was in final year at uni and our surgery faculty wrote in our yearbook, remember, a chance to cut is a chance to cure. And it turns out he was right. Over the last few years, a growing number of centres worldwide have been surgically correcting mitral valve disease. We have two guests today who are both overqualified to talk to us about this. Matteo Rossanese is one of our own who writes our surgical email updates, and Professor Dan Brockman, both from the Royal Veterinary College. They are authors of a recent publication on mitral valve repair in dogs entitled Improvement in Short-Term Outcome Over Time in a Single Centre Embarking on a Canine Mitral Valve Repair Programme using a structured multidisciplinary approach. Thank you both so much for joining us. This is a real treat.
Thank you very much for inviting us. It's great to be here.
Thank you, Simon.
Now, by way of introduction, Dan is Director of the Cardiothoracic Surgery Service. Matteo is Head of the Soft Tissue Surgery Service, working together intraoperatively in these patients. Now, if I may, I'd first like to just think about a few specifics of the procedure itself to give a bit of a glimpse to our listeners of what it involves. If I'm completely honest, I remember having some embarrassing light bulb moments when I first encountered these patients. So I'm going to start with the cardiopulmonary bypass procedure. If we say that the principle of that procedure is to create the surgical field to remove blood returning to the heart, oxygenate it, and then be responsible for pumping again back into the rest of the system so that you can stop the heart and open it and operate on it. What does that look like? So I want to know, you take blood from where and you put it back in where, and is it always the same sites, for example?
Matteo, do you want to make a start?
Yeah, I can start. So yeah, you said correctly. So we can call the cardiopulmonary bypass a technique which can be used for surgery of the heart and major vessels. Specifically, we use it for the heart to kind of take over the function of heart and lungs. And basically, the blood is diverted from the body to this machine, the heart-lung machine, which the aim is to oxygenate and also reduce the temperature and try to help to circulate the blood and pumping the blood and taking over from the heart. We have our own protocols. There are some variations of it. What we normally do is we insert what we call the arterial cannula into the left carotid. If we talk about mitral valve repair, we use the left one because it's on the same size of our approach. And we use the venous cannula in the right auricle, so on the right hand side of the heart. So the blood comes out from the right hand side of the heart and is pushed back in through the carotid. The only thing that we do, so another thing that we do is place a little cannula into the aortic root, which is called cardioplegia cannula, where we infuse this cardioplegia solution, which make the heart stop beating, but also protect the myocardium. So at this point, we basically reach the point where we are able to open the heart and have a nice surgical field with the heart that just stop beating.
And then the return of blood back into the arterial system is into a carotid. What direction does the blood go into that carotid?
Well, we're very lucky because the arterial tree is completely valveless. So where we access the arterial tree doesn't really matter because providing there is enough pressure being created, that blood will be distributed around the entire body. And that's something that is a concept that you have to sort of get your head around a little bit because everyone's familiar with the venous system being valved, but the arterial system is not. So that means we can access it from either the femoral artery, the carotid artery. In humans, the descending aorta is the place where a cannula is most commonly inserted for human open heart surgery. But that seems to be extremely dangerous, full of jeopardy in dogs, because the canine aorta is a little bit more fragile, apparently, than the human aorta. Because where we retrieve the blood from really depends on which side of the heart we're operating on. We were talking, and Matteo was referring specifically to the mitral valve approach we use for mitral valve, and that's what we have used most of the time. Other teams doing mitral valve surgery actually get their venous drainage by inserting a cannula all the way down the jugular vein into the right atrium.
Right.
And that requires a very special cannula with a very carefully designed tip so that you can get maximum blood retrieval for the size of the cannula. But if we wanted to open the right side of the heart, the most important thing about the venous blood retrieval is that you do it because we are usually relying on gravity and a siphon effect to pull the blood out of the body. We can't allow air to enter that venous system and block the venous system. So if we want to go onto the right side of the heart, we have to have cannulas that go from the atrium either down the caudal vena cava or up the cranial vena cava, actually, and both. And then we have to snare around those cannulas so that we don't get air entering the venous drainage system. And that's how we would access either the right atrium to repair an atrioseptal defect or to gain access to the tricuspid valve. But for the mitral valve, we're very lucky. We can just stick one drain into the right atrium.
Okay. More light bulb moments continuously. So then, if the other concept I wanted to just touch on is that when we talk about cardiopulmonary bypass, and if it's ever shortened to the term bypass, I feel like there's a little bit of room for confusion there, because in people, if you have a relative that has been in for bypass surgery, they're actually referring to something importantly quite different. They're saying, they're having a bypass graft placed on a coronary artery,
Yeah.
and having one, two, or three when you have single, double, or multiple, triple, etc., etc. Does that cause you any confusion?
It caused me a great deal of aggravation over the years, because I would really love for people to actually describe what we do as open heart surgery rather than bypass. Bypass is the process that
Yeah.
allows us to do open heart surgery. And so there's a whole array of procedures that we do, some of which we do on a beating heart, some of which, like mitral valve, we do on a paralyzed heart. But coronary artery bypass grafting, if you're in a human cardiothoracic team conversation, when they talk about bypass or cabbages, they call them,
Yeah, yeah.
coronary artery bypass grafts, that's a specific procedure, and that's not one that we do.
Yeah. Yeah, yeah. Okay, brilliant. If we move on sort of chronologically, broadly anyway, can I ask about when you would start anticoagulation in this whole process?
Well, I
Yeah.
can I can tell you a bit about it. It's actually something that I'm quite interested of, and I found it very fascinating and very difficult in these patients. So we start our anticoagulation so during the procedure. So when they are as soon as we do our approaches and we are ready to place the cannula in, the dog should be already anticoagulated with heparin. So they receive heparin as soon as we open the chest, more or less.
Okay.
And then toward the end of the surgery, we try to reverse that using protamine, which basically reverse the effect of the heparin. After that, to me, is still a very, as I said, fascinating area, because anything could happen. My feeling is like our attempt is try to keep them on a very fine line, I will say, between them not bleed out because of the surgery, because of the oozing that we can have post-op, and not producing blood clots that can be we can have both complication from this procedure. We continue with heparin during the entire hospitalization, which roughly is about 8 days, I would say, as average, more or less. And we start, if everything is okay, based on few parameters on the night of the surgery, in the evening of the same surgery, and then we continue during the hospitalization with heparin. And then we, again, as a protocol that we use and we are comfortable of, and other centers use slightly different protocols. For us specifically, we use a combination of aspirin and clopidogrel. And then we're going to continue this protocol for about 3 months. And in
Okay.
those 3 months, we're going to have obviously all the post-op checks with the echoes and at the hospital, and then one recheck after 1 month and one recheck after 3 months, making sure the repair is good, there is no blood clots formation around the surgical site, and so on.
Okay. So it's a case of surgical approach into the thorax, heparinized, reversed at the end of the procedure, so long as so long as there's no significant bleeding in the immediate post-operative period, back onto a low molecular weight heparin for the rest of hospitalization, and then on an antiplatelet therapy drug for about 3 months as a
Exactly.
general rule.
Yeah.
Brilliant. Okay. Cool. Okay. And then this takes us down to quite nicely the procedure itself. So the surgery itself. What does that look like, and how do you decide how much of an impact you need to have on that mitral valve? What are the specifics of the mitral valve repair itself?
Well, we're really trying to address two components of the consequences of myxomatous mitral valve disease in these dogs with acquired mitral valve incompetence. And the two components that we're trying to address are support for the valve leaflet edges, because this degenerative process frequently causes either stretching or results in a rupture of the chordae tendineae that suspend the valve leaflet edges. And that, of course, if a cord is ruptured, then the valve leaflet edge is free to prolapse into the atrium and create a large area, or what we call the area of regurgitation orifice. So, given that there are innumerable chordae tendineae,
Okay.
and far more than we could ever replace on a one-to-one basis, we tend to have a bit of a sledgehammer approach in that what we do is we identify any clearly broken ones, and we will target those areas for artificial cords, but we will really be trying to be strategic and supplement, augment, or replace other stretched cords that sort of evenly spaced around the valve leaflet edges. And that has two effects. One is it will restore the leaflet edge excursions almost instantly, but also because it's Gore-Tex suture material that we use, that will hopefully protect the valve, or at least the chordae, from further degenerative change, or at least if they do undergo degenerative change, it will protect them, the valve leaflets, against subsequent cord rupture. So it's got an immediate effect, and then it's got a long-term effect. The second component of the disease that we want to address is really secondary to the dilation of the heart that is experienced when dogs essentially have pendulous flow of blood backwards and forwards between the ventricle and the atrium, because that represents an overload of blood, causes atrial dilation and ventricular dilation, but also causes dilation of the mitral valve orifice or annulus. And so to create a better fitting valve, even though we don't remodel the valve leaflet edges that are distorted by this nodular myxomatous change. But if we can get the annulus back to a more normal size, we can get better coverage of the valve tissue that is present. And so we do what we call a purse string annuloplasty, which is again Gore-Tex suture material that's reinforced at the anchor points with Gore-Tex, little bits of Gore-Tex sheet or pledgets, so that we can pull the annuloplasty tight and create an orifice that is closer to what we think it should be. And we would use the size of the aortic root or the aortic valve annulus, also visual eyeballing the size of the septal valve leaflet of the mitral valve to get a sense of what is going to result in a more competent valve. And the septal valve leaflet is the dominant valve leaflet, but the parietal valve leaflet can also cause problems. So we will place, for let's say, for example, in a typical cavalier, may have 4, possibly 5 artificial cords in the septal leaflet, 3, possibly 4 in the parietal leaflet, and an annuloplasty. And then there becomes a fair amount of judgment, and something that we've learned and others have learned with experience is that occasionally we see deep fissures either within one of the major valve leaflets or between a major and a minor valve leaflet, such as the S2 valve leaflet and the S3 valve leaflet. So the septal valve leaflet is divided into S1, S2, and S3, with S2 being the biggest. But occasionally there can be fissures between the two that are resulting in a lot of regurgitation of blood. So we sew those together as well. It's one of those iterative processes. I think Matteo would probably agree with me that the repair we both do today is probably different from what we were doing 2 years ago, simply because we just got more familiar with what we need to do. But the goal is not to make the valve completely leak-free necessarily. That would be brilliant if we could do that. But the real goal is to restore enough competence to the valve so that the valve leakage is no longer hemodynamically significant. And critically is to use suture material that essentially locks the valve in that configuration, so that we not only get an instant improvement, but that improvement is durable.
And is it tend to be the case that the chordae tendineae are replaced first and then the annuloplasty, or are there iterations of both of those throughout the procedure?
Matteo, maybe you can.
Well, we start actually placing our cords, artificial cords, on the parietal leaflets to start with. And then we, let's call it, pre-place the annuloplasty, but we don't tie the annuloplasty because effectively the fact of having a big annulus is, from the surgical perspective, it helps with the visualization of the papillary muscle where we hook the artificial cords. So it's actually nice to place all the artificial cords when the annuloplasty is still not tied. So artificial cord in the parietal leaflet first. We pre-place the purse string sutures around for the annuloplasty. We place our cords on the septal leaflets, and then we start tying the cords where we want, at the level of the valve, just to avoid prolapse, and then we do the annuloplasty.
Brilliant. Okay. Thank you very much. I wondered if I might move on now just to what do you consider your ideal candidate for surgery, and has that changed over time too?
Maybe I can make a start on that. But obviously, when you're starting a program and you don't have a guaranteed outcome, or not as guaranteed as you hope it's going to be. You always start out choosing patients that are clearly and absolutely definitely in need of surgery. So we started out we started this program in 2012 with the help of a Japanese team. We started doing cases independently in 2014, 2015, but we were choosing using the ACVIM cardiology classification of clinical disease. We were choosing stage D dogs. So these were dogs that were almost refractory to all medication at very high levels.
Right.
So absolutely the most challenging set of patients, but justified in choosing those because we felt that was the only honest approach to take with those clients. And of course, the clients have to be fully aware of the risks and giving their full consent. Over time, things have changed, and I think probably we would consider our ideal candidate now as being a dog that's in early stage C. So a dog that has had a bout of failure, been rescued from that failure, typically by the addition of loop diuretics to the regime, along with some other medications, and that patient is a patient population that we know from previous studies, on average, has a life expectancy of about 11 to 12 months. Now, of course, I always talk to clients that the numbers we quote are on populations, not individuals. And that's one of the real challenges, is trying to predict how any individual is going to progress in terms of disease severity. And of course, there are other factors to take into account as well. We obviously want to try and be certain that in every other respect, the animals are healthy. And so comorbid disease is is an important thing to identify and can have a serious impact on chances of a successful outcome. But of course, it's a sort of a nuanced thing. We find some owners of dogs that have previously had dogs that they've witnessed die of heart failure that don't ever want to see that again. So they might push hard to have surgery before their dog goes into failure. So what we would consider late stage B2. And also owners of dogs that are in late stage B2 but are very young, because you know that they will need surgery at some point. So we might be more inclined to proceed with surgery in a very young dog with very advanced B2 rather than waiting for that dog to go into failure. It's very interesting because in humans, I think it's very clear that the earlier you intervene surgically, then the better the long-term outcome. But of course, they're measuring outcome in decades in humans rather than single integers of years. So it's a slightly different thing. The team in Japan that have the most experience of anyone are pretty convinced that dogs that are operated on in B2 will do better in the long term in terms of cardiac remodeling and long-term survival. But the challenge there is that we know we have dogs sitting on our waiting list in B2, even at what we consider advanced B2 on the basis of their echocardiographic parameters, but they're sitting there still 3 years later. So it's a real challenge to work out the best candidate. But at the moment, we believe early stage C is a good candidate, but we will accept late B2, and of course we will never deny a dog or an owner a chance at surgery just because their dog is in stage D. So we still do a fair number of stage Ds.
Yeah, yeah. Okay, brilliant. That would lead quite well into sort of expectations and outcome, but I might just come back a step and bring in the study specifically and just say what were your aims? Because it's an atypical study format, perhaps. So what were your aims of reporting what you reported? And one of those things that you reported was the outcome. So what can we expect in terms of outcome?
Yeah, so the reason that was constructed the way it was, and I think Matteo probably summarized it better when we were discussing it, it's a qualitative paper rather than a quantitative one. And so there are quite a lot of challenges when you're reporting the first 100 or 200 of anything, because that wonderful word, the learning curve, has an impact. So looking at the mortality rate and trying to unravel risk factors for mortality when what we're actually dealing with is a very, I think the term is a complex socio-technical environment. And what that means is there are multiple experts, if you like, working in concert to create one piece of music. And this one piece of music is very complicated. And there are so many factors that contribute to a successful outcome. And of course, there are so many factors that can contribute to an adverse outcome that trying to pick one or two things out of all of that is pretty meaningless.
Mm-hmm.
And so what I really wanted to outline for folks was what extent we needed to go to coordinate the effort to try and even achieve what we ultimately have achieved, which was a reliable outcome. And without being, that we were very fortunate in the 132 patients we reported, the mortality rate was so 20% roughly, and a relatively small number of dogs. What that means is that when you look at all of the different variables that could feed into that adverse outcome,
Mm-hmm.
The statistics would have been meaningless, because we really need to focus on when you have a small number of fatalities, then you really need to, you can't put 20 variables in that regression model and expect to come up with anything meaningful. So we felt we had something important to say that wasn't just this is our survival rate. We can see it's improved over time, and I think it's important to anyone thinking about doing this to understand it's going to take time to get to that place. But unpicking and saying, the dogs with a cross clamp time of this were more likely to die, we felt was pretty meaningless. So it was all about, this is a big effort and it's a team effort. And a lot of folks, we all have to, no one person can do it alone. Everyone has to leave their egos by the door as they come into this kind of endeavor and agree to work in a very well coordinated, carefully orchestrated way. And even if you do all of that, the times can be hard sometimes,
Yeah, yeah.
but it's worth it in the end. And that's really what we wanted to convey. There's a lot of folks out there who I think are considering starting a program
Okay.
like this. And I felt that whilst there's been some fantastic publications, and notably out of Japan, what the hidden story was the one that I wanted to try and tell, and that's why we tried to construct it that way, and I hope that that's viewed as a meaningful contribution, and be very worthwhile listening to any thoughts Matteo has, because whilst he was a valuable co-author, um, uh, in fairness, it probably was a little bit removed from the early days, and so maybe have a slightly more objective view on where its value lies.
Yeah, well, since the beginning, I was very keen on this paper, and I knew it wasn't the perfect paper for veterinary surgeries because, as we said before, they're more quantitative paper than only observational or qualitative. But I really thought that it was important to describe what has been done and what Dan started at the Royal College, because it is something extraordinary. If you think that there are only few centers in the world, and actually describing how everything has started and which disciplines are involved, and it is a real orchestra. And obviously, when I joined, it was already a good machine that was already working, and for me, it was very interesting. And sometimes, in retrospect, I think what I'm doing from the personal perspective. Sometimes I think, how did everything started? Because obviously now it's working, but I said someone at some point decided to go for it, and it was a huge step, very tough, obviously, and as Dan was saying, yeah, we work as a team, and there are many people involved in one single surgery, and everyone does the best they can do in that moment, and is a procedure and a surgery that humble you very frequently, and Dan knows very well because he rescued me many times. And every single mistake can be tough to resolve. So everyone really has to give the best that they can on every time that we go for surgery, and is to me is very fascinating and astonishing.
Yeah, yeah. And I would say for the listeners, I would really recommend having a read of the study. It tells a real story of
Exactly.
what has been necessary to generate that sort of machine as you described it as. And then yeah, demonstrating the improving outcomes over time. So just as a brief excerpt, the dogs were split into four quartiles, right? So the first quartile, we've got 22 of 33 dogs surviving to discharge, and by the final quartile, 30 out of 33 surviving to discharge. So it does tell quite a fascinating story, and there's plenty more detail in the text than we can cover on a podcast like this. I think that's actually it for today. I think that's a really nice tour. Thank you both so much for joining us. It's been a real pleasure. Thank you for sharing your expertise.
It's been great fun. Thank you very much for inviting us.
Yeah, thank you, Simon. That was fun.
The aim of VetLit is to make veterinary literature both more accessible and accessed, and hopefully we've secured that in some small way today. Remember, you'll almost definitely find an article to read that interests you on the vetlit.org site. You can check back here, there, or via the email updates for more. And otherwise, have a great day. It's goodbye from Dan and from Matteo,
Goodbye.
Bye bye.
and it's bye bye for me.